Good morning, Minister Much, Madam Chair, ladies and gentlemen. I'm very pleased to be here today and talk about what is one of the main public health challenges the world is facing today. So not just Luxembourg, not just Europe, but this is a global issue. I'm going to rely very heavily on work that I've been involved in or led over the past 10 to 15 years on the economics of obesity. But I should mention actually that we have new work funded by the European Commission that is going to start in a couple of weeks, that is going to focus particularly on children. It's a very big project that involves 25 different partners across Europe, and we really hope to have new evidence. So if you invite me again in 1 or 2 years' time, I hope to be able to, present a lot more new evidence on, particularly, as I say, on how to address the childhood obesity epidemic. But let me start by defining what we mean by the obesity epidemic. This is a chart, one of the charts that we included in our obesity publications at the OECD. This is 2014. There's been an update on this just last year, but the picture hasn't changed. This is the last one I was responsible for. This is essentially what we mean by the obesity epidemic, a staggering increase in obesity rates across, in this case, the OECD area, but as I said, I mean, it is really a global phenomenon. If you look at what happened since the 1980s, essentially, in some countries more than others, of course, but we see consistently that obesity rates have been increasing at a steady pace, and obesity has reached a degree of spread in particularly Western countries that was absolutely unthinkable at the end of the last century. As you see, I mean, some countries are starting from lower rates than others, but in all countries the progression of the epidemic has been consistently strong. And this is one of the most disturbing dimensions of the obesity epidemic. As I say, the obesity epidemic is affecting children to a major extent. These are millions of children. On the vertical axis you have numbers in millions of children worldwide, and how the childhood obesity epidemic has developed in the past 25 years roughly. What you see in the blue sections of this graph is Europe. So in Europe the childhood obesity epidemic is still growing. This is data that was just published a few months ago, so a very authoritative review of all the data that have been produced on childhood obesity at the global level. As I say, in Europe, childhood obesity is still growing, not as fast as it is growing in other parts of the world. And if you look at the most recent data, the number of children are obese outside Europe, and I would say even outside of the high-income part of the world, is now greater than the number of children obese in wealthy countries. So this is truly, as I say, a global epidemic that is increasingly affecting low-income countries to an extent that it is even exceeding the problem in high-income countries. Why are we worried about this? We're worried about this because this is an epidemic that leads to a large number of chronic diseases, major chronic diseases, and the burden that we are experiencing from these diseases has been growing at an incredibly fast pace over the past 25 years. This is data from the Institute for Health Metrics and Evaluation, which many of you would be familiar with. Those of you who know the color coding that the Institute for Health Metrics and Evaluation uses, essentially chronic non-communicable diseases are the ones in blue and purple. So if you compare the 1990s picture, which is at the bottom, with the 2015 picture at the top, the burden in terms of disability-adjusted life years lost from non-communicable diseases has been growing to a significant extent, and it has been particularly growing in the working age population. So these G20 countries, so advanced and emerging economies, if you look at those bars up to age 65, the growth in the burden from non-communicable diseases has been very large. And this has major implications on labor markets and the economy, of course. And this is why an economist is, from an economist perspective, there is a major cause for concern in obesity and non-communicable diseases that are associated with it. Obesity is a social phenomenon. We know that there are major social inequalities in obesity, and it is very disturbing that inequalities in obesity tend to affect women a lot more than men, and particularly women, young women of childbearing age. And as I will argue later on in my presentation, this makes obesity a sort of transmissible condition that is passed on from mothers to children, basically. In a way, not in a biological or strictly physical way, but in a social way, as I will explain later. But essentially, what you see is these are inequality indices, basically. So these bars, the higher these bars, the greater the degree of inequality in obesity in these countries. This is actually overweight. As you can see, in many countries, there are inequalities in men that are relatively small, but in women, inequalities tend to be much larger. And the extreme case in that graph is Korea, where women with low levels of education are 5 times as likely as women with high levels of education to be overweight. In terms of labor market outcomes, we've done a study that looked at women and men across Europe in the age group 50 to 59, looking at their probability of employment, looking at their wages, looking at the days of sick leave that they took off work every year. And essentially the conclusion is, if you look at the red bars in this graph, these, for instance, show the likelihood of being employed in the age group 50 to 59, while for obese people, the likelihood of being in employment is 58%, whereas in people who are not obese, that likelihood is 72%. So there's a major gap in employment between people who are obese and people who are not obese in that age group, which many of whom, of course, would have been obese as children previously. If you look at the number of days of sick leave that people take off every year, again, people who are obese and in employment tend to take 50% more days of sick leave every year compared to people who are not obese. So there are major labor market consequences from obesity. And one of the reasons why we are calling this an obesity epidemic, using a term that is more traditionally used for communicable diseases, is that there seems to be a sort of social multiplier effect. This graph shows that essentially boys and girls that have at least one parent who is obese are about 3 times as likely to be obese themselves as children who don't have any parents who are obese. So there is a very strong correlation in obesity within families. And you can see the same. There are plenty of studies that have shown similar findings across social networks, across peer networks, and even people who are friends and live remotely are more likely to share lifestyles and be obese, more likely to be obese if their friends and people in their social network are obese. So there is a kind of social transmission of obesity that is of major concern for society, and it is a very important dimension for economists in particular, because that can be read as a form of externality. You know, economists are very concerned about externalities. So when someone makes a choice, and that choice has an implication, has an impact on other people who are not involved in that choice, then an economist sees that as an externality. And in many cases, when we have negative externalities, that justifies public intervention that interferes with individual choices. And this is what we need in public health. I mean, we need to make a case for government intervention, which must be based on what economists call market failures, of which externalities are a major component. We know there is a very strong case for intervention in tobacco and alcohol, because there are major externalities in that case. People who choose to smoke, people who choose to drink alcohol cause damage to others, others who have nothing to do with their choice of drinking alcohol or smoking. The case for obesity interventions has been a lot more controversial because for many years people have not managed to demonstrate that there is a strong externality or a strong cause of market failure in the case of obesity. Now the evidence is beginning to emerge. The externalities are beginning to be quantified. The information failures and the behavior failures are also beginning to be quantified. And this contributes to strengthening a case for government intervention in tackling obesity. A major support to this case has been made by two Nobel Prizes in economics, George Akerlof and Robert Shiller, who published a book a few years ago, which is called Fishing for Fools, in which they've argued that manipulation and deception by commercial players have led people to make choices that are not optimal for their future health and social outcomes. And they have a chapter specifically on food in this book. They basically argue that this is a cause of market failure. This is a cause of market failure. And there are plenty of examples of this. I'm just giving you one. I mean, when you walk into a supermarket, you think you're perfectly able to choose and you go there to buy things that you were planning to buy before you entered the supermarket. In fact, it's not like this. I mean, when we walk into a supermarket, we are led to making certain choices more than others by, for instance, the way foods are laid out or products are laid out in the shelves of a supermarket. So there are lots of ways in which commercial players are influencing the way we make decisions, and they're influencing our consumption. Of course, commercial advertising is one of them. Which are causing a market failure because they're exploiting weaknesses in our decision-making process. And by doing this, clearly, they lead us to make choices that are not optimal for us, for our welfare. Governments have not exploited to a large extent the evidence from behavioral research that has emerged over the past 20 to 30 years. But they're beginning to do it now. I mean, there are many countries, the UK, for instance, has a behavioral insights unit within government that is helping government use this information from behavioral research to make better policies. And there are lots of behavioral failures in behaviors that are related with obesity. These behaviors are driven by social norms, and social norms are set by a number of players, including commercial players, as I said. They tend to be present-oriented, so the decision-making process is very myopic. That applies to both food and physical activity, of course, and we rely on habits. I mean, our consumption tends to form habits, and we tend to, continue consuming using the same patterns as a habit, as I say. So, in order to tackle all of this, governments have four different policy options. The first option is increasing choice. I mean, they can make choices available that wouldn't otherwise be available in the market. An example is that picture at the top, shared bicycle schemes. Only a few years ago, no one could have imagined that bicycles could be available for everyone to pick up in the streets in major cities. Now they're almost everywhere in every major city. So this choice option has been made available, and it is a healthy option that has added to the other transport options that people have. That is one example of how a policy can actually increase the range of choices available to people. The second level of policy is providing information, educating people, trying to change established preferences through nudging. We know that some of these approaches can be effective, but some are not. So I think it is important to go down the road that Pierre has explained, looking strictly at the evidence that is available and selecting the approaches that bear more potential for effectiveness. Then we can, of course, alter the prices of choices, of different choices, particularly hitting with taxes, for instance, the choices that are less healthy. There is an increasing number of countries that are doing this. Of course, we've been doing this for a long time on alcohol and tobacco. Now there is a very large number of countries that are considering or implementing taxes on sugar-sweetened beverages. There are some that have also considered taxes on, that have also used taxes on junk food or even fatty food. So this is an area that is expanding very rapidly, and the results are there. I mean, there are many evaluations that have now shown that this is an effective way of changing people's behavior. And then, of course, you have options. You have a policy level that is, banning unhealthy options altogether. Some of this has been, we have seen in the case of trans fats, for instance, which have been banned in some jurisdictions. But of course, it is not a policy that can be applied very widely in tackling obesity. Just to show you some results of a previous analysis that we have done on the effectiveness and the economic impacts of these policies. This is a ranking of policies based on their impacts on life expectancy and disability-adjusted life expectancy for Europe, different policies that governments can use to address obesity. Big effects you can see there from health system interventions, particularly primary care-based interventions, with counseling delivered by primary care physicians and dietitians. But also large effects from major regulatory policies that governments have been using in the past few years, like fiscal measures, like food labeling, like food advertising regulation, particularly advertising aimed at children. So the effects of these policies are sizable. They can be used in countries with major benefits, but they need to be used in packages, in combinations. I mean, individual policies alone clearly cannot achieve very much. And we also need to be aware of the time progression in the impacts of these policies, particularly what you see in the solid red line in this graph is a policy of regulating advertising, of food advertising to children, which is clearly aimed at a target group that will only develop chronic diseases later on in life. So the progression in the effects of these policies is very slow compared to some of the other policies that have a faster impact. So we need to be aware of what the time frame of these effects is and make sure that the mix of policies that we use have both short-term and longer-term effects. There's been a lot of concern about impact on inequalities because there is a common misconception that prevention will increase inequalities because it will be the better off or the more educated to take up prevention more than people of low socioeconomic status. In fact, in the majority of cases for the interventions that I've listed in my previous slide, the effect is exactly the opposite. This is, for instance, the impact of fiscal policies. If you look at the impacts in low socioeconomic status people, that's consistently larger than the impact on people of high socioeconomic status. Of course, there's been a big debate about the use of taxes because they are feared to be regressive, so they're feared to have financial consequences that hit the poor more than the rich. In fact, we have published a paper in The Lancet a couple of weeks ago that is precisely aimed at dispelling this myth. These taxes are not usually regressive. When they are, in the case of sugar-sweetened beverages, only in high-income countries, the difference between the tax burden for a low-income family and a high-income family is really trivial. I mean, it has been calculated as $8 per year in the United States, sorry, $4 per year in the United States, or £8 per year in the UK, with the sugar-sweetened beverage tax that has just been introduced. So it's really a minor effect that shouldn't be of concern for governments. So this is the comprehensive package that the OECD work has come up with, and what you see at the bottom is the implementation cost per year. I mean, we're talking about a very small implementation cost compared to what these countries are spending on healthcare more generally. So it's a trivial fraction of their healthcare expenditure, and even a small fraction of what they're spending on prevention generally. What we can achieve with these policies is major. I mean, this, for instance, is an analysis that looks at how many years of life free of cancer or free of cardiovascular disease would be gained by using that package of policies that I showed in the previous slide. Basically, we could gain, after 20 years, we could gain about 20 million years free of cancer and 10 million years free of cardiovascular disease in those 4 countries that are listed here: China, Brazil, Canada, and Europe as an aggregate. The financial impacts, I mean, there's been a lot of talk introduced in this session about the need for prevention as a way to avoid cure in the future. I mean, to some extent, prevention does avoid cure in the future, but in the case of obesity, it doesn't really in the majority of cases. I mean, cure is postponed. I mean, diseases will still occur because what we can achieve with prevention today, with the currently available prevention approaches, is relatively limited. So we can achieve a big benefit, but it will only postpone diseases instead of preventing them altogether. And that is why you see the picture that we have in this graph. The blue bars are the impacts on healthcare expenditure, so by how much each of these policies can reduce healthcare expenditures. The red bars are the costs of implementing each of the policies. There are very few policies that actually save more money in terms of future healthcare, reduced future healthcare expenditures compared to what they cost to implement. And these are the ones you see at the start, so voluntary initiatives or fiscal measures. The other policies all have an implementation cost which is greater than the savings that can be made in future healthcare expenditures. But should this be a reason for not using prevention? Certainly not. I mean, what matters is not the financial impact, strictly speaking. So it is not whether prevention saves money. Prevention is not meant to save money necessarily. Prevention is meant to be cost effective and more cost effective than what we do in other parts of the healthcare system. And from that point of view, prevention performs extremely well. So the cost-effectiveness ratio of investing in prevention is far lower than the cost-effectiveness ratio of most of the things we do within our healthcare systems today. So the return in terms of benefits for each unit of money spent. Let me draw some conclusions from this. So obesity is not just an individual issue. Behaviors need to be changed by changing the environment in which people make their choices. So we need to address the social and economic consequences directly, because we're not going to be able to eliminate obesity from one day to the next. It will take many decades before we see obesity rates drop in a significant way if we implement effective actions. So at the same time as we try to tackle and prevent obesity, we also need to address the social and economic consequences, particularly the labor market consequences and the education consequences through policies in those sectors that mitigate the impacts of obesity, existing obesity. Prevention can be effective and cost-effective, but clearly we cannot expect it to be saving money. I mean, we need to make investments in prevention because prevention sometimes is costly. We just need to be aware that the returns we get from those investments is very large and much greater than what we get in healthcare. Finally, a call for more research and more collection of data, because we have data everywhere, particularly from mobile apps and individually, and providers of these apps know everything about our lifestyle and what we do. But this information is not available for government policy, and that is a major limitation that we need to overcome if we want to improve government policy in the future. Thank you.